Hello. Before I get started with this video, please excuse me if I start coughing. I have a really bad cold. But today I want to discuss the ethical dilemmas associated with decision making for end of life. Two examples of the types of decisions needed during end of life treatment are discontinuing artificial nutrition and hydration and for end of life patients, and the rationing of scarce and expensive medical procedures and supplies. The first ethical dilemma involves the case of Brophy versus New England Sinai Hospital. In this case, Paul Brophy had suffered a brain aneurysm in March of 1983. He never regained consciousness. A peg tube was placed to supply his nutrition and hydration, and he continued living in a vegetative state until his wife requested that life-sustaining treatment be discontinued. On September 11, 1986, the Supreme Court of Massachusetts reversed an earlier decision and granted the discontinuation of life-sustaining treatment for Paul. And within 8 days of stopping the treatment, he died. They said it was very peaceful and he did not suffer. A second similar case I found was that of Terry Schiavo. Terry suffered cardiac arrest in her home in 1990. She lived in a persistent vegetative state until 2005. Her husband petitioned the court as her guardian to have life-sustaining treatment stopped, and he fought with the family. Life-sustaining treatment is expensive. She had a feeding tube as well, and it was used to sustain her life for 15 years. When facing end-of-life decisions, it's important that open communication between the doctors and families or patients be facilitated. The theory of autonomy applies. Physicians need to speak to individuals in a language that they fully understand, discuss the benefits and risks associated with life-sustaining treatment. They also have to be very forthcoming so that there are no unrealistic expectations as far as how much life-sustaining treatment will improve quality of life. Is it just sustaining the person, or is there hope that that person will improve? The virtue theory is also present in these examples because the doctor has an obligation to treat the patient for the greater good, or is seen in both of these cases to improve quality of life. The third theory is justice. We need to ask ourselves if using expensive treatment or procedures, scarce resources to sustain life where quality of life is minimal is futile. Guidelines and policies that are put in place, as well as educating the patient and the families, again, on the benefits and risks of any procedures or life-sustaining treatment, should be explored, and they need to fully understand how the procedure will, one, improve quality of life, or would it be better to seek out comfort care in order to improve quality of care and comfort through end of life. From a biblical perspective, God created all of us in His image. We as medical providers, we need to be good stewards of both, the lives that we're entrusted to care for, as well as the resources that we have. To me, this means that we need to be sure that if somebody is end of life, that life-sustaining treatment would be futile and would be, a hardship on resources that are already scarce. We have to ethically make these decisions to withhold treatment. Again, only if treatment to sustain life would be a burden to the individual and would not improve quality of life, but only prolong the suffering. And that's all I have for my first week video on the ethical dilemmas of decision making associated with the end of life. Thank you.